assume any small error that you make is squared. So that is the most area of potential error when you're using continuity equation. And then E, the mean aortic valve gradient measured by Doppler echocardiography is typically higher than that measure. So this one now is the reverse. When it comes to the mean gradient, the one at catheterization is higher than transthoracic, okay? But the peak gradient is higher for transthoracic than the peak-to-peak gradient in catheterization. So for this question, the correct option should be B, where in patients with low flow aortic stenosis can have severe stenosis despite a peak outflow velocity of only 2 to 3. Any comments on this one? Okay, should we read the answer? Hello? Should we read the answer and proceed? The line is broken.
Yes, then you can go ahead.
Okay. 47. 47 says, which of the following statements regarding the assessment of intracardiac shunts during cardiac catheterization is correct? Okay. 47. So, which of the following statements regarding the assessment for intracardiac shunts during cardiac catheterization is correct? So, A, in normal subjects, there should be no difference in oxygen content in different portions of the right atrium. B, because of the normal variability in oxygen saturation, shunts with pulmonary to systemic flow ratio, QP to QS, less than 1.3 at the level of the pulmonary artery or right ventricle may escape detection by oximetry run analysis. C, when shunt is bidirectional, its magnitude can be calculated as the difference between the pulmonary and the systemic blood flow as determined using the Fick's equation. And the D option, can you move the slide a bit? Okay. So, okay, D, in patients with a pure right to left shunt, the QP, the QS ratio should be greater than 1. Okay, so we can start from the D option. So if you have a pure right to left shunt, okay, there will be more flow to the left. Okay, more flow through the left than the right. Okay, so your QP, the pulmonary flow to systolic, should be less than 1 when you have a pure right to left shunt. Should not be greater than 1. So it's greater than 1 when you have left to right shunt. So D is false. Okay, let's go to the option. So 47. Okay, so C. Yeah, we're taking the C option. When a shunt is bidirectional, its magnitude can be calculated as the difference between the pulmonary and systemic flow, Q. So QP minus QS as determined using the Fick's equation. No, so this one does not apply to bidirectional shunt. So what this one would that difference, what it gives you is it will tell you the direction of the shunt. So if the pulmonary flow is more than the systemic flow, then the shunt is left to right. And if the systemic flow is more than the pulmonary flow, giving you a negative value, then the shunt is right to left. But it will not give you the difference in a bidirectional shunt. Because this formula does not hold for bidirectional shunt. B, because of the normal variability of oxygen saturation, shunts with pulmonary to systemic flow ratio, QPQS less than 1.3 at the level of pulmonary artery or right ventricle may escape detection by pulse oximetry. So this is 2, okay? Because when you have QPQ ratio less than 1.3, that means there is a very minimal shunting of blood. And if you use pulse oximetry method, you cannot detect significant change in the saturation. So that one can pass detection by based on saturation only. And in fact, you know, when you are looking at VSD, once the QPQ ratio is less than 1.5, it tells you that that's a restrictive, you know, VSD. Okay, there is not much flow of blood going from the left to the right. So a shunt that is less than 1.3 can actually go undetected by oximetry method. And then, so that is the 2 answer here. The A option says, in normal subject, there should be no difference in oxygen content in different portions of the atrium. So that is false. We know that when you're catheterizing, during right heart catheterization, the oxygen concentration in the superior vena cava is lower than the oxygen concentration in the inferior vena cava. So if you are sampling blood from the right atrium, all right, if you sample closer to the SVC, you get a lower saturation compared if you sample closer to the IVC. So various portions within the right atrium can actually give you different saturation levels. So that A is false. So the correct answer would be B. Okay, any comments or addition? Okay, 49. Which of the following statements regarding the auscultatory findings in aortic stenosis is true? All right. So A, initial squatting decreases the intensity of the murmur. Okay. B, the murmur is increased in intensity during the strain phase of Valsalva maneuver. C, in patients with premature ventricular contractions, aortic stenosis can be differentiated from mitral regurgitation because there is beat-to-beat variation in the intensity of aortic stenosis murmur, while the intensity of mitral regurgitation remains constant. Then D, respiration typically has a prominent effect on the intensity of the murmur. All right, so let's go through them one. So A, initial squatting decreases the intensity of the murmur. Okay, so that one will be false. So when you squat, you'll increase venous return, and therefore you will increase filling of the LV. And once that increases, then when the LV contracts, there is more increased flow across the stenos valve. So you would expect the intensity of the murmur to increase. Okay. B, the murmur is increased in intensity during the strain phase of valve. So that is false. During the strain phase of valve is the opposite. So venous return is decreased. So therefore, the amount of volume ejected from the LV will reduce, and therefore the flow across the aortic valve will reduce. C, in patients with premature ventricular contraction, aortic stenosis can be differentiated from mitral regurgitation because there is B. So this is actually true. Beat-to-beat variation occurs with aortic stenosis. And I don't think it occurs with mitral regurgitation. And then D, respiration typically has a prominent effect on the intensity of movement. So respiration affects right side murmur mainly. So with left-sided murmur, you don't have much variation with respiration. Okay, so I think for this question, the answer should be C. Any comments? Okay, 50. A 59-year-old business executive presents because of episode of retrosternal chest discomfort that does not radiate. It is an aching, burning sensation occurring most frequently at night, occasionally awakening the patient shortly after he has fallen asleep. It does not occur while walking or climbing stairs. His internist prescribed nitroglycerin, which he has taken infrequently. It does seem to relieve his discomfort, usually within 10 to 20 minutes. The previous day during a luncheon meeting, he had a severe episode while presenting a new financial plan. The discomfort seemed to lessen when he sat down and finished lunch. The most likely explanation for his chest discomfort is prismatal angina, esophageal reflux and spasm, pericarditis, unstable angina pectoris, then biliary colic. Okay, so let's try to eliminate. So I think E1 is out. Biliary colic, it's not the pain is not typical of biliary colic. Okay, unstable angina. So unstable angina will present mostly with rest pain, and they will have typical what you call it, typical ischemic pain. But you know, this one, the pain, the description of the pain, aching, burning sensation, okay, occurring most frequently at night, you know, then the patient, after the patient has shortly fallen asleep. So that one, for me, skews it a lot more to a reflux because it's burning, you know, and it's occurring after the patient takes the recumbent position, which, you know, precipitates reflux more. Pericarditis is out. This cannot be, it's not a typical pattern of pericarditis. And then prismatal angina. So prismatal angina, you can have unprovoked. So without exercise, you get the pain. But I think the burning sensation of the pain and the fact that the pain is worse when the patient lies recumbent, I would want to go for esophageal reflux and spasm, especially with the addition of the spasm, you know, because they mentioned that nitroglycerin provides relief. Nitroglycerin provides relief for cardiac ischemic pain because we know it causes coronary vasodilatation. However, it also causes smooth muscle relaxation. Okay, so when you have esophageal spasm, if you're having a pain as a result of esophageal spasm, it can actually be relieved by nitroglycerin. And sometimes it can make the pain of esophageal spasm difficult to differentiate from an cardiac ischemic pain. Okay, but for these patients, for me, because of the burning character and the pain happening shortly after he falls asleep, I would lean more towards the reflux with the spasm. So I'll go for B. Any comment? Yeah, hello. Sorry, I went offline a bit. I think it's the Zoom that went off. Okay. Is everyone hearing me?
Yes, we.
Okay. So we would continue, but I need someone else to take from 61 to 65. Someone else to lead as we all answer together. 61 to 65.
Good evening, Dr. Conte. Good evening, everybody.
Yes, please.
Please, I'm supposed to take 81 to 85. I don't know if we can go there.
We want to go, we don't want to skip. So the people that are not present, we want to just do the questions together. And then I don't know, probably we might get to your question before we end.
Okay.
So can I have someone else to volunteer to that? So 61 to 65. Okay. Dr. Sambo, do you want to help us?
Hello?
Yes, please.
Sorry, I wouldn't be able to. I am sorry. Maybe subsequently. I'm quite busy right now.
Oh, okay.
Sorry.
Dr. Okedara, can you help us?
Conte, please, do you want the question shared?
Okay, let me write. Is there anyone else who can share the BRAUNWALD'S so that Dr. Okedara can read the question?
Conte, please, can you see the screen I'm sharing?
Yes, yes. So go to
What number
61.
are you?
Question 61. 61.
I want to watch on something.
Wait, let me listen. The time is 8:15. Time for it to see.
Yeah, what is it? 61, eh?
Yeah, 61 to 65. That's what I'm saying. Let me just see.
Okay, so 61 is up.
Okay. 61. Which of the following statements concerning imaging findings in hypertrophic cardiomyopathy is correct? A. Septal thickness is always abnormal in patients with hypertrophic cardiomyopathy. B. Diastolic notching of the aortic valve on M-mode examination is typical in patients with outflow tract obstruction. C. The presence of systolic anterior motion of the mitral valve is consistent with dynamic outflow tract obstruction. D. Myocardial relaxation velocities measured by tissue Doppler imaging are typically normal. I don't know whether there is an E option. Okay, I think that's all. Okay. Let me start taking it one by one. Septal thickness is always abnormal in patients with hypertrophic cardiomyopathy. I don't know, the always in there is making me feel that this option is not likely to be true. But that option C, the presence of systolic anterior motion of the mitral valve is consistent with dynamic outflow tract obstruction. I think that option is the true one. Then option B, diastolic notching of the aortic valve on M-mode examination is typical in patients with outflow tract obstruction. I'm not sure. I welcome comments here. I'm not sure about that. Option B. Please, can we have comments at this point? I'm not sure about the options, which one is correct or not. Or should I read the answer?
Okay, I think the option C is because we are looking for one correct answer.
Yes, I know
And
C is correct, but I don't
option
know.
C is correct. And I've never seen anything like notching of the aortic valve for
So it occurs in cysto. You know, in M-mode, when you put the on the mitral, on the aortic valve, you know, it opens and fuses at the center to give you at the middle if it is tricuspid. Now, if you have an LVOT obstruction, it flatters and starts closing early and can come with a notch. So it occurs in cysto.
It closes early.
You see that in the M mode, you don't get a typical like the parallelogram shaped opening and closing of the aortic valve. It tapers very early from mid cysto. It tapers and sometimes you can have a notch come in there. So it's usually in cysto, not in diastole, but we can read the answer.
Not in diastole.
Yeah.
Oh, okay.
Okay, I have the answer. Let me read it. In hypertrophic cardiomyopathy with outflow tract obstruction, the anterior leaflet of the mitral valve is abnormally drawn towards the hypertrophied interventricular septum during systole. This systolic anterior motion of the valve can be readily identified by echocardiography and plays an integral role in the development of outflow tract obstruction in this condition. In addition, characteristic systolic, not diastolic notching of the aortic valve is often evident, particularly by M-mode recordings, owing to the dynamic nature of the obstruction. Asymmetric hypertrophy of the interventricular septum is common in hypertrophic cardiomyopathy and is readily identifiable by echocardiography. However, pathologic localized hypertrophy in this condition can instead be confined to the apex, lateral, or inferior segments, typically without dynamic outflow obstruction at those locations. Cardiac magnetic resonance imaging is complementary to echocardiography by visualizing regions that are difficult to assess by echocardiography. The Doppler spectral mitral inflow pattern in hypertrophic cardiomyopathy can be variable, but usually reflects the abnormal diastolic filling of the hypertrophied ventricle. Usually there is evidence of a diminished E wave and prominent A wave. Doppler tissue imaging typically demonstrates reduced early diastolic mitral annular velocity E prime as a measure of impaired myocardial relaxation. Okay, that's all.
Yeah, so we can proceed to the next question.
Okay. That's question 62. Okay, can you please scroll there? Okay.
Eugene, please scroll so that we can go to the next question.
Okay. Which of the following statements regarding cardiac hemodynamics is true? The wide descent of the right atrial pressure waveform represents relaxation of the atrium and downward tugging of the tricuspid annulus by right ventricular contraction. B. In the right atrium, in contrast to the left atrium, the V wave is more prominent than the A wave. C. The wide descent is blunted in cardiac tamponade. D. Tricuspid stenosis results in prominence of the wide descent. This question is talking about the JVP. Okay, let me start taking it. A. Wide descent. So we have to identify the waves that make up the JVP. We have the positive deflections include the A, the V, then we have the X descent and the Y descent. For the A is for atrial contraction. Then the X is, I think, when the pressure in the atrium falls during ventricular systole. Please correct me if I'm wrong. Then for the V,
You said the X is what?
I'm saying X is fall in the atrial pressure during ventricular systole.
Okay, yeah, part of it. So
yes.
the X descent has two parts. You know, the first part is actually atrial relaxation, and then after that, the notch, the C wave comes when the AV valve, the tricuspid valve closes, and then the remaining portion of the X descent is due to left ventricular contraction when the annulus is pulled towards the apex.
Okay, thank you. Now the next will be the V. That's the positive deflection. I'm trying to recollect. I think, is that not the filling of the atrium against the closed tricuspid valve?
No, passive filling.
Sure.
Passive filling of the atrium, yeah, during systole.
Okay. During systole.
During ventricular systole, yes.
Okay. Okay, please, I will really need your contributions to answer this question. A is saying the wide descent of the right atrial form represents relaxation of the atrium and downward tugging of the tricuspid annulus by the right ventricular contraction. I think,
yes.
First and foremost, I can't recollect what the Y stands for.
The Y is
the
just
Y descent.
rapid filling, rapid ventricular filling. So the first phase of filling of the ventricle. You understand? As soon as the AV valves open, that rapid filling is what causes the Y descent.
Okay. So this option A, Y descent of the right atrial pressure waveform represents relaxation of the atrium. So it's false.
Yeah.
It will be false. Okay.
Yes.
B says in the right atrium, in contrast to the left atrium, the V wave is more prominent than the A wave. I don't think I've seen anything like this. Like being a disparity between the right and the left. Then the Y descent is blunted in cardiac tamponade. I know that this is true.
Yes.
Because yes, in cardiac tamponade there is effusion, and it's working against the relaxation of the ventricles to fill. So definitely the Y descent will be blunted. So I think option C will be true.
Yes.
Then D, tricuspid stenosis results in prominence of the Y descent. If there's tricuspid stenosis, that means there is reduced filling of the ventricle. If there is a tricuspid stenosis, so this is not likely to be true. It cannot increase the prominence of the Y descent.
Definitely.
I think the correct option will be option C for 62.
Yeah, I think I agree with you on that.
Okay, so I'll just quickly read through the answer. The right atrial pressure waveform contains 3 upward deflections, including A, C, and V, and two downward deflections, X and Y descents. The A wave represents atrial systole and occurs after the P wave on the ECG. The X descent represents the relaxation of the atrium and downward tugging of the tricuspid annulus by right ventricular contraction. The C wave interrupts the X descent and represents the protrusion of the closed tricuspid valve into the right atrium. The V wave represents the passive venous filling of the atrium, which occurs during ventricular systole. The height of the V wave reflects atrial compliance. In the left atrium, as opposed to the right atrium, the V wave is generally more prominent than the A wave. So it's the opposite.
I see.
The V wave is more prominent in the left atrium compared to the right atrium. Okay. Then the Y descent follows the V wave, and it represents right atrial emptying after the tricuspid valve opens. Conditions that blunt the right atrial Y descent include cardiac tamponade, ventricular ischemia, and tricuspid stenosis. Conversely, constrictive pericarditis is associated with prominence of the Y descent because the very earliest phase of diastolic ventricular filling is unimpeded in this condition. Blunting of the X descent can be observed in atrial fibrillation. So So I'll go on to question 63. Which of the following statements regarding the effect of maneuvers on the auscultation of cardiac murmurs is true? A. In patent ductus arteriosus, the diastolic phase of the murmur is softened by isometric hand grip. Hand grip increases venous return. Saying the diastolic phase of the murmur is softened by isometric hand grip. I think that is false. I think it should be increased by isometric hand grip. Option B, the murmur of the hypertrophic obstructive cardiomyopathy becomes softer with standing or during a Valsalva maneuver. I think this is true because standing or a Valsalva maneuver will reduce venous return and make the murmur more harsh or louder.
Well,
Option
so
C,
then
the murmur.
So B will be false because it's saying the murmur becomes softer with standing and doing Valsalva.
Okay, yes. Okay,
false.
that's true. It makes it false. Thank you. The murmur of a ventricular septal defect decreases with isometric hand grip. I think this is also false.
Yeah, I think so.
Yeah. Then D, isometric hand grip decreases the diastolic murmur of aortic regurgitation. Okay, there will be increased venous return. Not sure. Does it decrease the diastolic murmur of AR? I don't think so.
I don't think so.
I welcome comments. I welcome comments. I don't think so. Because I think with increased venous return, there will be increased leverage and diastolic volume. Increase in the
there is actually they said that the strength phase of Valsalva maneuver and isometric hand grip are similar in action, as they also has to do with tensing of the muscles. And most times those isometric hand grip increases regurgitant murmurs rather than decreasing them. It increases the regurgitant murmurs. So most all the mitral regurgitation, aortic regurgitation.
So with hand grip, it should increase. It should increase. Option E, the diastolic murmur of mitral stenosis becomes louder with exercise. Yes, I agree with this.
Yeah.
Option E is correct. I think option E is the answer. Okay, and I'm looking at the code. Okay, E is the correct answer. Because with exercise, there will be increased pumping of the leg muscles, and there's increased venous contraction, increased venous return, and then there will be an increase in the mid-diastolic rumble of the mitral stenosis murmur. So option E will be the correct answer. So all the others are false. So question 64. A 62-year-old previously healthy man is brought to the emergency department because of severe headache and dizziness. He has no chest pain or dyspnea. He takes no medications. His blood pressure is 186/98 millimeter of mercury. His heart rate is 56 beats per minute and regular. The presenting ECG is shown in figure 1.15. Which of the following action is appropriate? Okay. So can you help us go to the ECG, please? Can you please help us scroll to the ECG? Okay, so this ECG, the one thing that is obvious on this ECG are deep symmetrical T waves, have T inversions in V2 to V5. And they're saying that this 62-year-old previously healthy man came with severe headache and dizziness, no chest pain or dyspnea, not on any medications, with a blood pressure of 186/98, heart rate 56. Which of the following option is appropriate? There are also T-wave inversions in 1 and AVL. Okay. So A, initiate antiplatelet therapy.
I think this patient most likely has intercerebral hemorrhage.
What? Okay, intracerebral hemorrhage.
Or things that increase intracranial pressure, they are likely cerebral T waves, as is called mostly in the to make it easy.
Pressure is high, pulse is these are these features
56.
Yeah, so he has a Cushing's triad likely. If you look at the BP is high, he has a bradycardia. We didn't talk about the respiratory pattern, but likely he has increased ICP with cerebral T waves.
Hypertension.
Yes,
okay,
with cerebral T waves. So the T waves are likely cerebral T waves from increased intracranial pressure.
Okay. Yeah, thanks for the contribution. So which of the following action is appropriate? A, initiate antiplatelet therapy with aspirin and clopidogrel. B, initiate antithrombotic therapy with heparin. C, initiate anti-ischemic therapy with intravenous nitroglycerin and beta blocker. D, proceed directly to cardiac catheterization if ST segment and T-wave abnormalities fail to quickly normalize with anti-ischemic therapy. E, obtain a head computed tomography scan. So
the answer is likely E.
The answer is option E. Yes, the answer is option E. That's question 64. You're right. So the answer is option E, saying although the findings on this ECG may suggest MI, the deeply inverted T waves are typical of acute cerebrovascular conditions, including subarachnoid hemorrhage. Given the present symptoms of headache, nausea, and dizziness, a cranial imaging study such as CT should be obtained rapidly. In this scenario, antiplatelet agents and antithrombotic therapy should be withheld until intracranial bleeding has been excluded. In the absence of findings to suggest unstable myocardial ischemia, anti-ischemic therapies and cardiac caths are not initially appropriate. Electrocardiographic abnormalities are present in a large percentage of patients with acute cerebral events. These abnormalities may include tachyarrhythmia or bradyarrhythmia, conduction disturbances, repolarization abnormalities that resemble myocardial ischemia, prolongation of the QT interval, and prominent U waves. The mechanisms responsible for such ECG changes are unknown, but appear to be related to abnormal autonomic nervous system function. Myocardial damage with release of serum markers, that is cardiac specific troponin, CKMB, and subendocardial hemorrhage can be observed in the setting of acute severe cerebrovascular disease believed to be related to the release of excessive local myocardial catecholamines. In the appropriate clinical situation, diffuse deep T-wave inversions are also found in some patients with hypertrophic cardiomyopathy, giant inverted T-waves in the mid-precordial leads, are particularly characteristics of the apical form of HCM. Okay. So I'll go on to question 65. Which of the following statements about diastolic murmur is false? A. Diastolic murmurs are classified according to their time of onset as early diastolic, mid diastolic, or late diastolic. I think that's true. In aortic regurgitation due to aortic root dilatation, the murmur typically radiates to the right sternal border. False. Aortic regurgitation from aortic root dilatation, the murmur typically radiates to the right sternal border. I think aortic regurgitation murmur usually radiates to the left sternal border. Okay, let me continue. It is possible to differentiate the murmur of acute severe aortic regurgitation from that of chronic aortic regurgitation at the bedside. Okay, I don't know this. D. Late diastolic, that is presystolic accentuation of the murmur, indicates that the patient is in atrial fibrillation. False. Because there is already a loss of atrial kick in atrial fibrillation. So I don't agree with this option D. The Graham-Steele murmur begins in early diastole after a loud P2. What is Graham-Steele murmur? Can anybody assist with this?
Pulmonary regurgitation.
Pulmonary regurgitation, okay, from increase in left atrial pressures. Okay. So now they're saying Graham-Steele murmur begins in early diastole.
Yeah, that
after
is
a loud P2. So
that
which of them is false?
Graham-Steele murmur, not usually early diastole.
Sorry?
The Graham-Steele murmur, I think, is mid diastolic.
No, it's
early. It's early diastolic.
It's early
It's
diastolic.
early diastolic murmur. Early diastolic. Okay.
Yeah.
Okay, so that means option E is true.
Yeah.
Okay. Now we are
yes,
looking for the one that is false.
Sorry, it's true.
A is true. E is true. That this option B, aortic regurgitation from aortic root dilatation, murmur typically radiates to the right sternal border. Typically, I think this is the false option. I don't know. Please assist me.
No, they're looking for the false. I think that is
You're looking for the false.
Yes. And then the false option is this D. Late diastolic accentuation of the murmur indicates that the patient is in atrial fibrillation. That is the reverse.
That's
you
the
understand?
reverse.
When you have mitral stenosis, you can only have this presystolic accentuation when they are in sinus rhythm. So once they go into atrial fibrillation, you lose that. You don't get the presystolic accentuation anymore.
Okay, yes. The option, I agree with that option. Since there is a loss of the atrial kick in atrial fibrillation, you cannot have that presystolic accentration. So that makes option D false. So all the others are true.
Yeah.
Okay, should I read the answer?
Yeah.
The details that were given? Okay, 65. Diastolic murmurs are classified according to their time of onset as early diastolic, mid diastolic, or late diastolic. Early diastolic murmurs include aortic regurgitation and pulmonary regurgitation. I think that's the diagram still. AR begins with the aortic component of the second heart sound, S2, and PR starts with the pulmonic component of S2. Mid and late diastolic murmurs begin at a clear interval after S2. When the murmur of AR radiates selectively to the right sternal border and not the left sternal border, it implies that aortic root dilatation rather than aortic valve disease is the cause. The murmur of acute severe AR differs importantly from the murmur of chronic severe AR. The high-pitched murmur of chronic AR begins with the aortic component of S2 and has an early peak and a dominant decrescendo pattern throughout diastole. In contrast, in acute severe AR, e.g. caused by infective endocarditis or aortic dissection, the diastolic murmur is of short duration and tends to be soft because the aortic diastolic pressure rapidly equilibrates with the steep rise in diastolic left ventricular pressure. Pre-systolic accentration of diastolic murmurs owing to atrial activation and a transient increase in driving pressure is typical of patients with mitral or tricuspid stenosis who are in sinus rhythm. Such accentration is absent in atrial fibrillation because of the lack of organized atrial contraction. When pulmonary regurgitation develops in the setting of pulmonary hypertension, the murmur begins with a loud P2 and may last throughout diastole, the Graham-Steele murmur. Okay, so that brings me to question 65. We just finished 65. Should I go on to 66? Well, I don't know whether the person to present that is around.
No, I think we did 66 to 70. So we should go to 71 to 75.
Okay. 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 Question 71.
Sorry, is Dr. Adebite not here to take his own part? All right. Okay, we can move on. But I don't know if anybody has if anybody's ready to present theirs.
So there's one person for 81 to 85. But
Okay.
we've decided not to skip any of the questions. We just go orderly.
Okay.
Yeah,
Okay.
maybe for those that are not here, we do them together.
Okay, that's fine. Thank you so much.
Okay, question 71. Which of the following statements about digitalis induced arrhythmia is correct? A. Atrial tachycardia with block is diagnostic of digitalis toxicity. B. Non-paroxysmal junctional tachycardia is highly suggestive of digitalis toxicity. C. The development of atrioventricular dissociation in a patient taking digitalis is a sign of digitalis therapy, but not an indication of digitalis toxicity. D. Frequent ventricular premature beats are rarely a sign of digitalis toxicity, which is correct. Atrial tachycardia with block is diagnostic of digitalis toxicity. I need help here, please. I don't know this. I know that last option is not, I don't think it's the frequent VPs, ventricular premature beats, are really a sign of digitalis toxicity? I think one would see ventricular premature beats in digitalis toxicity. And they're saying frequent is they are really a sign. Development of AV dissociation in a patient taking digitalis is a sign of digitalis therapy, but not an indication of digitalis toxicity. I think this is also false. Then I'm left with options A and B. B says non-paroxysmal junctional tachycardia is highly suggestive of digitalis
I think
toxicity.
this is also false. Atrial tachycardia with block is diagnostic of digitalis toxicity. You know?
So that leaves us with B, rule and divide. But I don't know why. That's rule and divide. I mean, we are striking. C and D, they cannot be true. You will see VPCs in digital toxicity, and then the normal treatment with digitalis cannot be giving us AV dissociation. So that's how we ruled out C and D. Then A2 is also ruled out. But now B, non-paroxysmal junctional tachycardia, is highly suggestive of digitalis toxicity. Any contributions, comments, someone that knows, that can remember digitalis toxicity stuff?
I think you should read the answer.
Okay, I'll read it. A large number of arrhythmias may result from digitalis excess. These include bradyarrhythmias related to enhanced vagal tone, e.g. sinus bradycardia or arrest, or atrioventricular nodal blocks. A large number of arrhythmias may result from digitalis excess. These include bradyarrhythmias related to enhanced vagal tone, such as sinus bradycardia or arrest or AV nodal blocks, and tachyarrhythmias attributed to delayed after depolarization triggered activity, such as atrial, junctional, and ventricular tachycardias, e.g. atrial, junctional, and ventricular tachycardias. One of the most common manifestations of excess digitalis is the appearance of ventricular premature beats. However, because these are morphologically similar to ventricular premature beats of other causes, they are not highly specific for digitalis toxicity. When ventricular bigeminy occurs, varying morphology of the VPBs is suggestive of digitalis excess. Some forms of ventricular tachycardia are also more indicative of digitalis toxicity as the cause, including ventricular tachycardia with exit block and bidirectional ventricular tachycardia. Atrial tachycardia with block may be caused by excess digitalis, but can also occur in the setting of structural heart disease without digitalis toxicity, so thus it's not diagnostic. The rhythm must be distinguished from atrial flutter, and because of the amplitude of the atrial depolarization may be low, this rhythm is sometimes difficult to recognize. Non-paroxysmal junctional tachycardia is highly suggestive of digitalis excess, although other causes of this rhythm must be excluded, including myocardial ischemia, recent cardiac surgery, and myocarditis. The term non-paroxysmal refers to the gradual appearance and disappearance of the rhythm. The majority of patients with this arrhythmia demonstrate AV dissociation due to acceleration of the AV junctional pacemaker. AV dissociation that appears in the course of digitalis therapy should be considered a sign of digitalis intoxication until proven otherwise. Thank you. Okay, question 72. An 82-year-old man presents after a recent non-ST. An 82-year-old man presents after a recent non-ST elevation myocardial infarction. Coronary angio revealed severe tree-vessel disease with 100% occlusion of the proximal left anterior descending coronary artery, 100% mid-right coronary artery occlusion, and 70% stenosis of the proximal left circumflex coronary artery. Echocardiography demonstrated akinesis of the entire anterior wall septum and mid and mid and apical anterolateral wall with an estimated left ventricular ejection fraction of 20%. Myocardial viability was evaluated using cardiac positron emission tomography with REST rubidium 82 RB flow tracer and F-labeled fluorodeoxyglucose. As shown, which of the following statement is true? The images show a large region of PET perfusion metabolism mismatch in the mid-LAD distribution. This thing that we've been saying we have to do a lecture on. Wow. I need help. Call for help. Who knows how to read these images, these perfusion images?
Chief Alison, please, do you have an idea? Chief Orimalade.
Good evening, everyone.
Yeah,
Good evening, Chief.
Oh, this is Dr. Basui. Good evening.
Oh, Dr. Basui, good evening.
Yeah, good evening. Well done, Dr. Kidara.
Thank
I
you.
want to make an attempt because I think I have something like this as part of my questions. So I've read a little about PETs, positron emission tomography. So PET is a kind of molecular imaging and is used to determine flow. So it's used to determine flow, myocardial blood flow, or myocardial perfusion. And there's also a part of it that is used to determine metabolism. So they use flow tracers and metabolic tracer. So the metabolic tracer that they used here is the rubidium 82. I think there's another one, nitrogen 13 ammonia tracer is also a flow tracer that can be used instead of this rubidium. Then for metabolic tracer, they use the FDG, fluorodeoxyglucose. What they do is that for the flow, they just check for blood flow, same thing that we want to do via a PCI or something. So they use that as a relatively non-invasive modality for checking myocardial perfusion. But for the metabolic aspect, they determine the uptake of the FDG, and it's used to see if myocardium is viable or not. So the picture we have before us, so the way to interpret it is this: for the flow tracers, they measure at rest and during stress. So stress can now be physiological stress, maybe on a treadmill, for patients that can reach the optimal stress, physiological stress demand. I can see we're doing the stress ECG testing. Then those that cannot would have to use pharmacological modalities, like using the dipyridamole and the likes. Whereas so what they want to see is what the perfusion is like at rest and during stress. So how to interpret it is that for a normal myocardial perfusion, at rest, there's homogeneous flow. That's there will be no thinning out at any particular region at rest. Whereas during stress will induce obstruction. So you will notice that there will be some thinning out or like a defect in the perfusion during stress for the flow tracers. So the same thing with the metabolic tracer. You expect a uniform uptake when the myocardium is viable, both during at rest and during stress. But like I said, we're talking about myocardial variability. So when you compare the flow tracer images with the metabolic tracer images, what happens is that for an hibernating myocardium, the flow will be reduced to that area because some sort of ischemia has already occurred, but there is no cardiac myocyte loss yet. There's some myocardial injury, sorry, if I put it that way. Injury has occurred, but there's no ischemia yet. So the myocytes around that area, they are hibernating. So you will see that there will be defects in the flow when you do a flow, that's the rubidium testing now. There'll be a reduction in the flow. But when you now do the metabolic FDG tracer, when you now use that, there will be increased uptake. That's how you know that myocardium is hibernating. Whereas if it's a scar tissue, that's when there's already myocyte loss, both the FDG will show reduced uptake, and then the rubidium scanning would also show a filling defect. So they will be. I don't know if we get what I'm trying to explain. Actually, it took me a while to kind of grasp what they're trying to say.
Okay. Can I echo what you just said now? I think you said that when there is hibernation of the myocardium, yes, the FDG, the rubidium uptake will be reduced, while the FDG the uptake will still be normal. As opposed to if the a part of that the myocardium is already infarcted, the rubidium uptake will be reduced, and the FDG will also be reduced. So in hibernation, yes, FDG will be normal, rubidium will be reduced.
Normal or increased.
Normal or increased. While in an infarcted myocardium, both rubidium and FDG will be reduced.
Yes.
Okay.
Yes. So if we look at the last two columns of this picture by our right hand, it shows the second to the last is the FDG metabolism, and then the last column is the RB, that's the rubidium flow. So if we look at if we look at the second line, you can see that there's around between 5 and 6 o'clock, there's like a thinning out in the flow. I've forgotten how they say this. In the flow perfusion, there's a thinning out there between 5 and 6. Between 5 and 6 o'clock, there's a little thinning out there in the last two columns, the last two images. On the first two is what they call the short axis. The The second two is it's called the vertical long axis, and then the last two are the horizontal axis. That's what they call those views. So for the short axis views, between our 5 and 6 o'clock, there's a little thinning out of the both the flow tracer and the metabolic tracer uptake around that region. Okay, same thing with the middle two, the vertical axis. Around between 3, 4 o'clock, we can see the thinning out of the uptake too, both at rest and the second one should be during stress. During stress, we can see that they open up.
Okay.
That they open up. Then same thing with the last two, the horizontal axis views. At rest, we can see the thinning out of the uptakes for both the FDG and the RB flow around 12 o'clock, and then which appears to be the same with the lower version. So this just shows us that there's reduced flow, which means there's obstruction. When we use the RB flow, there's an obstructive coronary lesion there. And the fact that the FDG uptake is also low at that time shows us that is likely a myocardial scar. There's no viable myocardium there. Because if there was viable myocardium, it should have given us a normal or increased flow at that same point where the rubidium flow tracer was thinned out. I don't know if we understand what I said, please.
Thank you very much. Thank you so much. I think for this particular, I think maybe we'll have to get, you've done really well. I think we'll need to get maybe one of our seniors to also elaborate more on this, because I think most of us have our weaknesses here. So maybe when we are having our curriculum topics, maybe we'll need to call maybe one of our seniors to help us out. Thank you so much for your contribution. It's well appreciated, well understood. Thank you.
Thank you. Thank you very much.
Thank you, Dr. Vasi.
Sorry, I can just say something. Thank you so much, Dr. Vasi. What she said actually true, but it's just to emphasize that as part of our MCQs, you have to note what an hibernating tissue is and what is termed myocardium is. The question will come out, part of the MCQ. So anytime they are talking about maybe there's a problem with a myocardium and there was a reperfusion, you understand? When there's reperfusion and the myocardium didn't pick up, you know that's a stunned myocardium. But hibernating, you understand? There's no reperfusion yet. Do you get what I'm trying to say? There is, like she explained, both at when you use the tracers, either metabolic, or you at first when you do the stress, the myocardium, there's a problem, obviously, obstruction. When you now do the metabolic tests, for the metabolic tests, there is high uptake. It just means that the myocardium is hibernating. But when they talk of stunned, that's when they introduce reperfusion. So even after like reperfusion now, the myocardium didn't pick up. So you know that's a stunned myocardium. But an hibernating myocardium after reperfusion, because the uptake and everything are usually high, after reperfusion, they pick up with the function. So when you see in the MCQ questions, and they are talking about a reperfusion, and still there's no uptake, you know, that's stunned myocardium. It's like they're giving you everything. You are just looking, you are still stunned. Just cramming that way. I'm not sure if you get, just like the explain. Do you understand?
Okay.
Because, yeah,
Yes.
because question, yes. So the question will come like that. After reperfusion, the myocardium is still looking at you. It's not picking up. It's just stunned. You have all the nutrients. It's not picking up. It's stunned. That's just the stunned myocardium. By hibernating with the tracer, there will be increased uptake. Do you understand? So that's hibernating myocardium. Learn those definitions and cram them for MCQs, really. Then also in MCQ, they are going to ask the materials that are used. That's the dyes and the materials that are used for all these and testing, the metabolic testing, the stress testing, the questions in the MCQ. So the rubidium is important as well as other ones that were there in the MCQ. I can't remember now. But they will write the following can be used maybe in PET scan. They will now list it except, you understand. So you must know those materials, that the dyes that are being used. Thank you.
Thank you so much, Chief. Thank you. Thank you. Well appreciated.
Thank you, Chief. So I will go on and complete reading the options, and then I'll read the. So let me just quickly go through it again. A 2-year-old man presents after a recent non-ST elevation MI. Coronary angio revealed severe tree vessel disease with 100% occlusion of the proximal left anterior descending coronary artery, 100% mid-right coronary artery occlusion, and 70% stenosis of the proximal left circumflex coronary artery. Echo demonstrated akinesis of the entire anterior wall, septum, and mid and apical anterolateral wall, with an estimated LV ejection fraction of 20%. Myocardial variability was evaluated using cardiac positron emission tomography with rest rubidium and F-labeled fluorodeoxyglucose. Which of the following statements is true? The images show a large region of PET perfusion metabolism mismatch in the mid left anterior descending artery distribution. So for this option, I think this option is true, because from the explanation that Dr. Basti gave, when we look at that upper panel at the 5 let me see, at the 5
Kidara.
Yes.
No, Dr. Kidara.
Yes.
Yes. This A option is going to be false, because if we
False.
look at the pictures, especially the last two will I call it rows now, columns?
The
The
last
image is actually similar.
rows. Okay.
Yeah, the images are actually similar, as in there's no difference in the images we are getting for the FDG tracer flow or the rubidium flow, which means that we're having the same. If we're having a hibernating myocardium, for the FDG tracer should give us an increased or normal flow. So there should be a disparity if it's an hibernating myocardium. But the tracings are like almost equal. Maybe if they are not labeled, maybe we would have thought that they were the same thing. So for this one, it shows scar tissue because there's no uptake. There's reduced flow there, and there's also reduced uptake of the FDG metabolic tracer. So for this one
is the last 2 rows.
Yeah, the last 2 rows.
But to me, it's looking like the last row compared to the row just before it. Like there is look at that 12 o'clock area. It's looking clearer in the last row compared to the second to the last row.
Okay, so maybe I mean the column then. I'm looking vertically now from top to bottom.
Okay.
From top to bottom, the last two images from top to bottom, they practically show the same thing. Difference is that one is at rest, one is during stress.
Yes.
But we have similar images.
Okay.
So where we find, okay, if I say let's look at the middle two. The middle two, which was flags. The one on top, we'll see around 3-4 o'clock. There's a thinning out there.
Yes.
The thinning out there, which is not present in the image below, under it. But the thinning out is present in almost all those images on that row. And don't forget that I said that those last two from top to bottom, second to the last is FDG metabolism. The last one is the RB flow. So it's actually one is a metabolic scan, the other one is a flow scan, the perfusion scan. So they want us to compare. So the areas where the defect, that thinned out area, is the same in both. That means both for flow and for metabolism, there's no response. And that's diagnostic of a scar tissue.
Okay.
If it was a if it was for an hibernating myocardium, the flow will be reduced there because we know that there has been some obstruction of flow to that region. But if the myocytes are hibernating, the uptake will be normal or increased.
With the FDG?
So in the FDG, if it was a stunned myocardium. So this reduction in both of them, the FDG and the rubidium, shows that there's no uptake. So which means that there has been some myocyte loss there. So it's like a scar tissue, it will take up. There will be no flow there and it will not take up the metabolic traitor.
Okay. Thank you.
So so in essence, you're saying that the myocardium is stunned in this scenario.
No, myocardium is scarred myocardium. That's
if
present
there
for
is no uptake in both.
Because there's no uptake in both. Both of them are reduced.
So which one are you comparing? Because from what you've explained, it seems as if there is a difference. The one at rest is showing low perfusion, but when they do the FDG, you are seeing increased uptake.
Please, can you look for the last two from top to bottom? The last two.
From top to bottom, the last two.
Bottom, yes. The last one shows RB flow.
Please,
so that's the rubidium.
Yes, at the top, they put RB flow there.
Yes. Then the
second to the top.
Okay, sorry, I was actually looking at the window. Yes. So when you look vertically from top to bottom, the last image, the last series of images.
Yeah.
Labeled RB flow. So that's the rubidium flow. That's the myocardial perfusion flow image.
Yes.
Yes. Then the second to the last, the one before it, that's the FDG, that's the metabolism tracer image. So we're actually comparing side by side.
No, if you look, the top row, so for each set of image, the first row, okay, is the rest image, and then the second one is the FDG gated. See, rest gated, FDG gated. Because that's the way I understand it. So this is a short axis view. So you have the one at rest and the one with the FDG stress image. So the first row is the rest. Okay, and it shows mainly the perfusion using the rubidium. And then the second row is FDG gated. So it's when now you give the FDG to see the metabolism in the myocardium. And from this first one, just this short axis view, you can clearly see that just the perfusion using the rubidium flow, if you look specifically at the last image on the right, you would see that, how would I say? So So if we say, let me just use the pace of the clock, from like 5 o'clock, you know, from like 5 o'clock on to 12 o'clock, you can see there is reduced intensity, so that reduced flow in that region. Okay. And when you come to this, the second row, you look at the FDG image now. That row is lighting up nicely. In fact, the entire right around the circle is lighting up. And that row that is not lighting up in the rubidium flow is even lighting up more in this one. So so that one to me will demonstrate a flow metabolism mismatch. Okay, there is reduced flow from there, but the metabolism is intact. And I think that one will go more for what you call it, a hibernating myocardium. And then if we come to the second set, which is showing the, I think this is the vertical long axis, okay, which is showing the anterior, inferior, lateral wall, and the septal wall. Okay, so here again, if we go to the last set of images, the top one and the bottom in this second set of images, you see again, you know, the apical part. In fact, especially at the apex, there is almost no flow. You don't see anything, and then reduced flow along the anterior, you know, towards the lateral. The inferior has some flow, okay? And then when you come to the FDG, it lights up very nicely. You see that metabolism is going on there. It's just the flow that is reduced. Metabolism is intact, but flow is reduced. And I think it's the same thing. Even the last set of image is the same thing that you are seeing. The areas that you don't have enough lighting in the flow image, but when you come to the metabolism image, they light up clearly. I think from what you explained, this one actually demonstrates an hibernating myocardium rather than a scar, because you can actually see a mismatch in the rest image where you don't see enough flow in a particular area, but when they do the stress with the FDG, you see the areas light up.
Thank you very much for the clarification.
Yeah, thank you. I think it's just the orientation of the diagram. Those first two rows were labeled for us to be able to use it for the second 2 rows and the third 2 rows. So the RB flow is for the upper line, and the FDG is for the second line, for for the 3 parts. I think that's exactly to be able to compare.
Thank you very much for the clarification.
Then maybe another thing too that we should take notes with this diagram, because you know in the questions we're asking for the arterial territory. If you look at the first 2, you know, don't raise it up, please. Still on the diagram from the up, yes. You know, on our short axis, you know, you can have at the base, that's the level of the mitral, at the papillary muscle, then going to the apex. Those are the 3 levels where we look. So if you see the first 2 rows, they are getting to the apical parts. Do you understand? Of the short axis? You know, we have different segments. If you remember, these are our segments by speckle or segments by, when we are looking at the arterial territory from the short axis view and the long axis view. So it's just telling us the arterial territory, the first 2 and the last 2, for instance, now describes where we expect to see the arterial territory, where the supply, that's the apex and the lateral, and the arterial territory is the left anterior LAD. You understand? The inferior left out here. So this is just like the apical lateral, because this the first 2 is like the short axis at the apex, has passed the level of that's after the papillary muscles. Those are the first 2. In this long axis, cutting it in the other way, still telling us that the inferior part is out of it. The main problem is anterolateral apex. I'm not sure if you are getting what I'm explaining, but it's just telling us the arterial territory, and it's showing us the same thing and these cuts that they are showing us. Yes. So we should just like we do those segments are the things that they are trying to ask We had a question in our exam, and they will ask you some questions. They will ask you the arterial territory based on what you say. Thank you.
Okay, thank you. So I'll read that option again. The images show a large region of PET perfusion metabolism mismatch in the mid left anterior descending distribution. So the left anterior descending distribution is this.
So it's showing the apex anterior and mostly
Yes.
apical and anterior. Yeah.
Yes. So that, going by all that we just talked about, that option is there's a mismatch.
Yeah.
So option B, this finding is consistent with the presence of scarred non-viable myocardium. So that's false.
So that would be false, yes.
That would be false. Then C, radionuclide techniques are less sensitive than measurements of inotropic contractile reserve by dobutamine echocardiography for the detection of viable myocardium. I think that's also false.
That's also false. So the echocardiogram is less sensitive but more specific when it comes to detecting viable myocardium.
Okay.
Stress echocardiography is less sensitive.
Okay. Survival benefit associated with revascularization of hibernating myocardium has been demonstrated in randomized clinical trials. I don't know. Survival benefit. I don't know.
Sure.
There was no survival benefits in the studies. That they had one with cabbage, and then we have a recent one. They had a recent one with PCI. They improved functional capacity, but they didn't improve survival.
Survival, okay.
Yes.
Okay, thank you. So that's sorry, that was question.
So the answer would be A.
The answer is A.
Maybe A. No.
The answer is A. The answer is A. So going on to question 73.
Survival benefit.
Which of the following statements regarding physical findings that distinguish the murmur of aortic stenosis from the murmur of hypertrophic cardiomyopathy is true? A. The strain phase of the Valsalva maneuver decreases the intensity of the murmurs of both AS and HCM. False. We mentioned this earlier that Valsalva maneuver would reduce venous return and would increase the murmur of aortic stenosis. I'm not sure. I know it would increase the intensity of the murmur of hypertrophic cardiomyopathy. Will you do the same for aortic stenosis?
No.
No, it would increase that of aortic stenosis.
Yeah.
Okay. So the Valsalva maneuver would increase that of HCM and decrease that of AS, since there is a reduction in venous return. Okay.
Yes.
So the option B, the carotid upstroke in HCM is brisker than in AS. Carotid upstroke in HCM is brisker than in AS. Okay, let me close.
Yeah, I think that is true.
That's true. You have a delayed upstroke in AS.
Okay. Thank you. The murmurs of AS and HCM both radiate to the carotid arteries. False. That of AS radiates to the carotid artery, but not that of HCM. If a systolic trail is present, it is most often located in the second right intercostal space in HCM and at the apex in AS. I think that of the HCM is in the left-right intercostal space. This is also false. Option D is also false.
Is it the one for HCM would be located where?
The left, right. They're saying right intercostal space in HCM.
So no, it's AS that is located in the second right intercostal space. Okay, in HCM,
yes, so AS is second right.
The left lower sternal border. Yeah,
okay.
Left lower sternal border.
Okay, squatting increases the intensity of the murmur of HCM. That is also false. It will reduce the intensity of the murmur of HCM. So which is true?
Yeah.
So the option that is true is option B. Carotid upstroke in HCM is brisker than in AS. So option B is the true option. I don't know whether there are extra comments or should I continue? Okay. So question 17.
I just want to find out the murmur of HCM, where does it radiate to? The systolic murmur of HCM. We can read from the answer.
Okay, let me go to 73. Okay, I'm sorry. Let me just read. For 73. Both aortic stenosis and hypertrophic cardiomyopathy cause harsh systolic murmurs, but these conditions frequently can be differentiated by physical examination. For example, the carotid upstroke quality is different. In aortic stenosis, there is fixed outflow obstruction, and the carotid upstrokes are diminished in amplitude and delayed. Pulsus parvus et tardus. In contrast, the carotid upstroke in HCM is initially brisk, then diminishes in mid-systole as the left ventricular outflow gradient becomes more pronounced. Another differentiating feature is the pattern of radiation of the murmur. In AS, the systolic murmur radiates to the carotid arteries, which is not the rule in HCM. If a systolic trill is present, it is usually located in the second right intercostal space in AS, whereas it is more likely to be felt at the fourth left intercostal space in HCM. Fourth left intercostal space in HCM. Dynamic bedside maneuvers. Yes. Dynamic bedside maneuvers are helpful to distinguish AS from HCM. Physiologic maneuvers that enhance contractility increase the intensity of both murmurs. Maneuvers that reduce LV feeling, e.g. strain face or Valsalva maneuver or standing from a squatting position, decrease the intensity of the AS murmur. But in HCM, the decreased intraventricular volume causes LV dynamic outflow obstruction to intensify, and the murmur of HCM becomes louder. The murmur of HCM diminishes in intensity with maneuvers that augment left ventricular feeling, such as sudden squatting from the standing position. Okay, that's it.
So, is it that the murmur of hypertrophic cardiomyopathy does not radiate at all? Because they are silent on it. They are silent.
Say you feel the trill. If there's a trill, you feel it in the left, in the fourth left intercostal space.
But the radiation, they did not They didn't mention.
Okay, I'm sorry, Dr. Conte. Dr. Conte, okay, where I'm reading from it, they said it radiates to the left neck and then it's accompanied by a palpable thrill.
Radiate to the left neck.
Yeah, to the neck, but to the left side of the neck, and then it's accompanied by a palpable thrill.
Okay, because now this book they are saying the murmur of AS, the Braunwald is saying the murmur of AS radiates to the left carotid, and then they say it's not the case for HCM.
In AS, the systolic murmur radiates to the carotid arteries.
Which is not the rule in HCM.
In HCM.
It's a bit confusing.
If a systolic thrill is present, it is usually located in the second right intercostal space in AS.
The thrill is fine. Yeah, we get that. It's the radiation of the murmur that is still ambiguous. Because now they're saying the left neck. Then I don't know. It's a bit confusing.
Actually, I've never read something about where the murmur of HCM radiates to. I always know about the double apical impulse and where to feel the thrill. But where it radiates to, I'll have to just check that up. We will have to check it up.
Yeah. Okay. Proceed.
Okay. For 74, which of the following statements is correct regarding the oral
Sorry, that is that question. Sorry to take you back.
Okay.
So I'm just reading here that it radiates to the suprasternal notch, but not to the carotid arteries or neck. That's the murmur of HCM.
Of HCM, so suprasternal notch.
Yes.
Hey. Then Florence is reading from another reference that is saying the left neck.
Well,
what I'm seeing here from Wikipedia.
How reliable that is, but that's where I'm reading it. But it actually tallies with the explanation in the Braunwald. That's how you differentiate it with the murmur of AS. So this tallies with that explanation.
So the suprasternal notch.
Yes, not to the carotid arteries or neck.
Okay.
Yeah.
Thank you so much.
Sample, please, what's your source?
Just check Medscape.
Okay. Thanks.
Yeah. Mm-hmm.
Okay. Thank you. The next question is 74. Which of the following statement is correct regarding the oral anticoagulants dabigatran, rivaroxaban, and apixaban in the treatment of patients with atrial fibrillation? A. These agents are as effective as warfarin for prevention of thromboembolism in patients with atrial fibrillation and mechanical heart valves. False. B. Each of these drugs can be used safely in patients with advanced renal disease. Each of these drugs can be used safely in patients with advanced renal disease. But I think there is usually caveat for reducing the doses for renal dose reduction. I think that's also false.
Yes.
For the
C.
direct acting factor 10 inhibitors.
Yes, rivaroxaban, yes. C. Intravenous idarucizumab rapidly reverses the anticoagulant effects of dabigatran. False.
True. It's true.
Yeah. True.
That's a reversal agent. It's a monoclonal antibody.
Yes. It's for the dabigatran.
Yes.
Yes.
And the Neza alpha is for the factor 10A inhibitors.
Which one is
Zana alpha is for the direct acting factor 10A, endozaban, rivaroxaban, apixaban.
Okay. Thank you. For patients whose international normalized ratio levels on warfarin are varied due to non-compliance, rivaroxaban is an excellent alternative, given its once daily dosing. For patients whose INR levels on warfarin are varied due to non-compliance, rivaroxaban is an excellent alternative, given its once daily dosing. We are looking for the true option.
We're looking for the true option.
Yes.
I think
and we have picked C as to be true.
D can be true, but you can argue it out. But C is true. I mean,
C is very true.
D is incomplete.
C is very
in the question, and in that answer is incomplete. So the rivaroxaban can be alternative in which cases? It's not like, for example, patient with mechanical
renal
valve
problem or something. You say it's excellent.
So rivaroxaban cannot be alternative for those patients. I think the
I get
answer
your point.
is not complete.
Yes, there are caveats to it. What if patient has end-stage renal disease? You say it's an excellent option. So the answer from the book is C. Is C. So C is true. So it says direct thrombin inhibitors, dabigatran, and factor 10 inhibitors, rivaroxaban and apixaban, are non-vitamin K antagonist oral anticoagulants approved by the U.S. Food and Drug Administration for the prevention of stroke in patients with non-valvular AF. Each of these agents has been shown to be non-inferior or superior to warfarin in efficacy and to produce less serious bleeding than warfarin. Additional advantages of these agents over warfarin include a fixed dosing regimen, no need to monitor lab tests to assess degree of anticoagulation, rapid onset of action such that bridging therapy with parenteral agents is not necessary, fewer drug interactions, and no important food interactions. Disadvantages compared with warfarin include higher costs and restricted use in patients with mechanical heart valves. Indeed, dabigatran resulted in more thromboembolic complications and greater bleeding risk compared with warfarin in the Realign trial of patients with mechanical valves. The dose of each of these agents must be adjusted in patients with renal dysfunction. Despite its once daily dosing in patients with AF, rivaroxaban actually has a shorter half-life, 5 to 9 hours, than do apixaban or dabigatran, which is 10 to 16 hours, which are administered twice daily. All of these agents lose most of the anticoagulant effect after 24 hours of discontinuation, so they do not offer an advantage in patients with drug non-compliance. The antibody fragment idarucizumab binds dabigatran with high affinity, forming an essentially irreversible complex that is cleared through the kidneys. It rapidly reverses the anticoagulant effect of dabigatran, and dexanate alpha is approved to reverse major bleeding in patients taking apixaban or rivaroxaban. So I'll go to question 75. A 73-year-old woman with exertional angina is referred for a standard Bruce protocol exercise tolerance test with gallium-201 single photon emission computed tomography. And nuclear images are shown in figure 1.18. What is the likely diagnosis? A, dilated cardiomyopathy. Let me look at this. I'm trying to, I need contributions here. I'm trying to interpret these images. And it's different from the ones that we have seen before.
Well done. I didn't read single photon. What's it called? Single photon tomography. But if I would use the previous knowledge for those ones, I don't seem to see any filling defect or reduction in caliber of any area that is being imaged, both during stress and rest. So if I'm to hazard a guess here, I would likely say it's normal coronaries or something. But like I said, I didn't read I didn't read about photon tomography.
So looking at it closely, so if we look at the first row that gives the short axis, one thing that is clear is that in the rest images, you see that the
cavity is smaller and the walls are thicker.
Diameter is smaller, yes, compared to the stress image. And usually when you have that, is a sign of ischemia on this one, when there is increased volume with stress, okay, LV volume with stress. And then also, if you come to look at the second row, okay, the second row, the second onto the third image on the second row, the second set of images. So the rest images are showing good uptake from the second, third, fourth images. But when you look at the stress, you see that it is less bright. Usually on the, now I need to get oriented. See, this one is showing inferior and anterior. So in the inferior walls, the uptake is less in the stress image compared to the rest image. Okay. And then if we look at the last row, so this one is showing lateral and septal. I think the septal should be up and then the lateral down. I don't know. So if you look at this one also, when you look at the rest images, if you look from the second, third, fourth, and fifth, you'll see that the upper limb of the image, let me just put it like that, the upper limb, which I think is this, I don't know, is it the lateral or the septal? I'm not sure. But when you look at the stress image, the intensity is lower compared to the rest image. So there is some perfusion defect during stress with associated chamber dilatation. And that is an indication of ischemia, you know, affecting the corresponding region. Yeah. So let's look at the options and see what we can make out of it.
Okay. So the options. What is the likely diagnosis? A, dilated cardiomyopathy. B, single vessel coronary artery disease involving the left circumflex artery.
Even those territories.
C, prior inferior myocardial infarction with high-grade stenosis of the right coronary artery. D, left main or severe multivessel coronary artery disease. E, normal coronary arteries. The images demonstrate breast attenuation artifacts.
Breast attenuation gives you fixed defects. You don't see changes. So that one is out.
That's out. There won't be thinning of the wall, or the thickness will remain the same in breast attenuation. Wow.
So which one? They say multivessel. I think I would lean towards that because I could see there was an inferior, and then there was also in the image showing the septal and lateral, there is defect there. Okay, that is, you can also see a defect in the image that is showing the inferior and anterior. So I don't think it's a single vessel territory. I think it could well be a multi-vessel disease, especially with the associated dilatation during stress.
Okay.
That's what I would go for.
Okay, I'll just read the answer.
The territories on the nuclear imaging is something that's confusing. I need to look at it. Yeah.
The answer here says D.
What is D?
Left main or severe multivessel coronary artery disease.
Okay. Oh, I got
It
that
says,
one right.
Yes, let me just read it out. This single photon emission computed tomographic images demonstrate transient ischemic dilatation of the left ventricle during stress. The size of the left ventricular cavity appears larger in the exercise images than in the rest images. This phenomenon is typically due to extensive exercise-induced ischemia with transient LV dysfunction and dilatation. In some patients, the appearance of LV chamber dilatation is actually due to the development of global subendocardial ischemia with reduced tracer uptake along the internal border of the left ventricle. As a result, there is the appearance of a larger chamber without true chamber dilatation. Regardless of the precise underlying mechanism, transient LV dilatation is a high-risk marker of severe ischemia and correlates with extensive coronary artery disease, that is multivessel or left main coronary artery, on angiography. Similarly, increased lung uptake is another marker of extensive coronary artery disease and indicates increased risk for an adverse cardiac event. LV dilation that is present both at rest, LV dilatation that is dilatation that is present both at rest and with exertion would be typical for dilated cardiomyopathy. Nuclear images of a patient with chest pain due to single vessel disease of the left circumflex artery would likely demonstrate a reversible isolated perfusion defect at the lateral or posterior wall. For the patient with prior inferior myocardial infarction, a fixed inferior wall defect with or without partial reversibility would be expected. Breast attenuation artifact typically appears as a fixed defect of the anterior or anterolateral wall. A number of techniques have been developed to reduce the likelihood of a false positive test due to breast attenuation artifacts, including the use of technetium-99m based agents and ECG gating. Thank you. So I've just finished question 75. Can someone take 76 to 80? At least we have the person that will take 81 to 85 around.
I think we have like 7 minutes more. I don't know.
Oh, that's true.
Florence,
No,
what do you think?
I didn't look at the time.
I think if we have somebody who has prepared for 81 to 85, I think the person can just take, once it is 11 o'clock, we stop. Then tomorrow we'll start from 76.
Okay.
I think it will be a lot faster because this person has actually searched through. So once it is 11 o'clock, we'll stop, then start from 76 for tomorrow.
All right.
Thank you so much. Thank you.
Okay, thank you very much. So please, can we scroll to question 81? Okay. So 81 says, which of the following is not often associated with a prominent airway in ECG lead V1. So the R wave, like we all know, is the first positive or upward deflection after the P wave, and it represents early ventricular depolarization. So the abnormalities that we may find on about the R wave on ECG ranges from finding of a dominant R wave in V1, a dominant R wave in AVR, or poor R wave progression. So this question is about the abnormalities of, the abnormal finding of dominant R wave in V1. So a dominant R wave in V1 may be a normal phenomenon in children, seen in children or young adults, or in adults who have persistent infertile pattern. Then can also be seen in cases of right ventricular hypertrophy, where we expect the ratio of the R wave to the S wave to be greater than 1, or the R wave amplitude should be greater than 7 millimeters. Then it can also be seen in cases of right bundle branch block, posterior myocardial infarction, the type B Wolff-Parkinson, type A Wolff-Parkinson White syndrome, where we find the delta wave to be upright in the precordial leads. This also makes the R wave prominent in the precordial leads. Then, in cases of incorrect lead placement, in cases where we push the V1 lead, normally V1 should be in the 4th intercostal space on the right. But if we push it lower down, as what we call the V1 to V3 reversal, we may start getting high amplitude R wave on that V1 lead. So dominant R wave is also seen in dextrocardia, seen in cases of hypertrophic cardiomyopathy, where there might also be RV involvement. And then in dystrophies, myotonic dystrophies, and Duchenne muscular dystrophy. So back to our question, the options. Prominent R wave seen in ECG lead V1 in RVH. So we're looking for the one that is not often associated. We won't see a prominent R wave in that case. So for RVH, that is false, because we'll find a dominant R wave in RVH. Wolff-Parkinson White syndrome, like I've explained, for the type A, we would find a dominant R wave. Duchenne muscular dystrophies, we'll find a dominant R wave. Then left anterior fascicular block, so that will be false. And that would be the true option here. That's, we won't find a dominant R wave. What happens in left anterior fascicular block is that we have a left axis deviation. The axis is about between -45 degrees to -90. Then we have the prolonged R wave peak time that we have is seen on AVL. Then you now have what called the RS complexes, small r and a large S complexes in the inferior leaves. That's 2,3 AVF. And then small Q and R complexes, that's a little Q and R. So the dominant R wave for left anterior fascicular block will be seen in lead 1 and AVL, and not in V1. Misplacement of the chest leads, like I've said, if we bring down the V1, V2 leads, if we bring them lower down, that's below after the 4th intercostal spaces, we may now start having prominent R waves for wrong placement of leads. That's what is called the V1 to V3 reversal. So the answer for 81 is D, left anterior fascicular block. It's not associated with a dominant R wave. Do we have any questions or comments? And should I continue? Hello? Hello, can anyone hear me?
Yeah, it's clear. You can continue.
I can hear you. Stay. Thank you.
Okay. Okay, thank you very much. So the question number 82, the hemodynamic tracing shown in figure 1.19 is associated with which of the following features? So this is an hemodynamic tracing. We can see the red, the tracing in red is for the LV, while the tracing in blue is the aortic pressure flow or pressure measurement. And then the first three readings was taken in the mid cavity, whereas the last three was taken at the subaortic LVOT. So the background here is that, as we can see here, in the LV mid cavity, there's a disparity between what is measured for the left ventricle in the mid cavity and what is measured in the aorta. So the LV pressure here, mid cavity pressure, is way higher than that of the aorta, that's the aorta. And then when we get to the subaortic left ventricular outflow tract area, we can see that they seem to balance as they achieve the same height. So there is no pressure gradient there. So this is what is seen typically in hypertrophic cardiomyopathy. So in hypertrophic cardiomyopathy, we all know there is a dynamic obstruction. So sometimes in the around the mid cavity region, you find the pressure gradient. So this is what is called the LV to aortic gradient, pressure gradient. And this is high because it's as much as about, it's going towards 100 millimeters of mercury here. When you check the difference between the height of the pressure in the aorta and that's in the LV mid cavity. And this changes as the obstruction has been surmounted. When it's close to the LVOT, it equalizes. Whereas if it was in aortic stenosis, the pressure gradient should persist because the obstruction is at the valve area, it's at the aortic valve itself. So whether mid cavity, whether at the subaortic valve area, pressure measurements should be equal. So the pressure gradients should be the same because we have not passed the obstruction. But for the hypertrophic cardiomyopathy, the obstruction is usually around the septum, maybe the mid cavity in this case. That's why the pressure in the mid cavity is way higher than what you will find at the subaortic region. So that's the background to what this tracing, this pressure tracing is saying, this pressure time tracing is saying. Then if we look at the aortic tracing too, this is what we call the spike and dome appearance. The spike and dome appearance is also typical of Ocum. It's said to be a bifid aortic pulsation. And the dome is due to late dynamic obstruction. So it's as if you have two peaks here. So the first peak is sharp, and then the second peak is a little bit, is not as sharp as the first one. So that's the dome. But if it is aortic stenosis, what we find is what we had talked about before, the slow rise. So we're not going to see this sharp spike. We're going to see a slow rising. So it's going to be more of like dome shape ab initio. And then we won't find this second spike here. Another thing to take note here is also that these horizontal lines on the red tracing, as for the LV gradient, pressure gradient now, they are just below 20. That's 20 millimeters of mercury. And they signify the LV end diastolic pressure. So if I'm to approximate here, I may say that the LV end diastolic pressure here might be just a little bit below 20 meters of mercury. And we know that in hypertrophic cardiomyopathy, the LV end diastolic pressure is elevated. Okay, so I'll go ahead and try and answer the questions for the options now. So A, so the question says hemodynamic tracing illustrated in this figure is associated with the following features. A, advanced valvular aortic stenosis. So I'll say that is false because I said that in advanced valvular aortic stenosis, that's severe aortic stenosis, we expect that the pressure gradient should persist, whether in mid-cavity or subaortic region, which is not so here, so that's false. So B, a bifid aortic pulse contour is present here, so which is true. As I've explained, this is the spike and dome appearance of a bifid aortic pulse. Then C, normal left ventricular end diastolic pressure. That is false. Like I said, in hypertrophic cardiomyopathy, the LV end diastolic pressure is usually elevated, and it is said that the normal LV end diastolic pressure should be less than or equal to 12 millimeters of mercury. And from this graph, we can see that it's closer to 20. It's closer to 20 millimeters of mercury, so it's definitely elevated. Please, can we go to the next option? Thank you very much. So D, a delayed rise in carotid artery pulsation. I'll say that is false too, because like I said, we can see the peaking as a steep rise in that arterial pulsation. It is said that the aortic pulsation and the carotid pulsation should be the same if there are no obstructions or there are no stenosis between both. So it should be, the aortic deflection should actually be, or better still, the carotid deflection should be a reflection of the aortic deflection. So the aortic deflection that we've been given here shows a sharp increase in the initial pressure. Whereas if it's the delayed, like we expect in aortic stenosis, we should see a gradual increase, which is the delayed upstroke. So that also makes that option false. Then expected clinical improvement with transcatheter aortic valve replacement. So like we have said, the condition here, the clinical condition here is hypertrophic cardiomyopathy. So aortic valve replacement have no role to play. Rather, things like septal myomectomy, alcohol ablation, and then maybe the new medical therapy now for hypertrophic cardiomyopathy like mavacamten. Those are the things that will play a role in the management here. I don't know if we have any questions or comments as regards this. Hello?
Hello?
Yes, do you have any questions or comments?
No, no.
Okay.
I don't know if any other person has a question.
Okay, thank you. So do I continue? Some people are leaving.
Yes, please continue.
Okay, thank you. So question number 83 says, a 53-year-old woman with a history of hypertension and obesity is diagnosed with triple negative, estrogen receptor negative, progesterone receptor negative and 2 negative left breast cancer. She undergoes echocardiography that shows a left ventricular ejection fraction of 65% and an average global longitudinal strain of minus 18.3%. And then the strain image is shown in figure 120A. She undergoes neoadjuvant therapy with paclitaxel and cisplatin. And after surgery, she's treated with adriamycin, a total of 240 milligrams per meter cubed, and cyclophosphamide. She undergoes updated echo 6 months after the first echocardiogram and prior to initiating therapy with trastuzumab that shows LV ejection fraction of 60% and a GLS of minus 14.4%. And then the image is shown. She has no symptoms or signs of heart failure. Her heart rate is 50 beats per minute. And her blood pressure is 130/77 millimeters of mercury. Renal and hepatic function are normal. What will be the next appropriate step in management? Okay, so this question is about drug-induced cardiotoxicity. And it's something that is common in patients who have had antineoplastic agents like anthracycline, cyclophosphamide, and 5-fluorouracil. So, and it's said to occur via 2 mechanisms. There's a type 1 cardiotoxicity and type 2 cardiotoxicity. Type 1 cardiotoxicity is when cardiotoxicity occurs by cardiac myocyte death. And this occurs either by necrosis or apoptosis and is said to be irreversible. Whereas type 2 is cardiac myocyte dysfunction, which may be reversible if noted early. So this patient actually had adriamycin, and adriamycin is said to cause cardiotoxicity via type 1. So adriamycin will cause irreversible cardiotoxicity. So hence the need for the surveillance, early surveillance, and then prevention. So for the surveillance now, we've seen here, the GLS, global longitudinal strain, is used to assess cardiac myocyte contractility. The usual thing is the GLS, any GLS greater than minus 16% is said to be normal. So as at the time before this patient started our medication, our treatment, the GLS was minus 18.3, which is within normal. And as we can see in the A part of the figure here, that's the bullseye plot here, we can see that it's mostly red. There's a little, like a color code by the side. The closer you have to minus 20, the better. So closer to minus 20 gives us this bright red, even though we can see some little pink areas in the anterior and septal area, but they are mostly bright red. So that's good cardiac myocyte function at that stage. Then we can see the image 6 months later, which shows a pink area in the posterior aspects. That's in the inferior part of that bullseye plot. We can see a pink area with reduced GLS in that segment. Okay, and we also note that, as said in the body of the question, the average GLS has dropped to minus 14.4%. So to define cardiac dysfunction following or cardiac chemotherapy-related cardiotoxicity is said to have occurred when there's a decrease in left ventricular ejection on echo that's the decrease is greater than 10% decrease. So For this patient, the decrease is just about 5% because our LV ejection fraction and echo initially was 65, and 6 months later it was 60. So even though our LV ejection fraction for this patient has only decreased by 5% from baseline, or using the GLS, if the GLS has reduced by greater than 15% following chemotherapy. So for this patient, our GLS reduced from minus 18.3 to minus 14.4%. So that difference is about a difference of, sorry, I just want to make the calculation now. 18.3 minus 14.4%. So the difference is minus 3.9%. So if I want to check what the percentage difference is, that's about 21.3% reduction in our GLS 6 months after chemotherapy has occurred. And I said that for GLS, cardiotoxicity for GLS is when greater than 15% has occurred. So using the GLS modality here, this patient already has cardiotoxicity. So they are now asking us, what would be the next appropriate step in management? One, proceed with trastuzumab treatment plan. That will be false because we already said that this patient has cardiotoxicity. We do not want to expose her to more antineoplastic agents that would further worsen her, further worsen her cardiac function, even though she's not yet symptomatic. And another addition is that what GLS does is it helps us to pick subclinical LV dysfunction before the overt symptoms or overt reduction in the LV ejection fraction occurs. So 2, pause the treatment plan and repeat echo in 3 months. That's also false. Pausing the treatment plan aspect of this answer is correct, but just repeating the echo in 3 months without an action doesn't mean that there will be a change. Because like I said, anthracyclines like adriamycin, they cause cardiotoxicity by myocyte necrosis and apoptosis. So it's usually irreversible. So there's actually no need to just pause medications, pause treatment, and just wait. There's need for an action to be taken. Then the next option is to start carvedilol. Then the D option is start lisinopril. So carvedilol and that's beta blockers and AC inhibitors have actually been shown to help to delay progression of cardiotoxicity to overt heart failure. So this patient would actually benefit from either carvedilol or ACE inhibitor. But for this patient, we are told that the heart rate is already 50 beats per minute. So she already has a bradycardia. We wouldn't want to administer beta blockers here. So that's why starting lisinopril ACE inhibitors will be the best option for this patient at this point. I don't know if we have any questions or comments as regards this.
Okay, thank you so much. Okay, just an add-on. Okay, if she had come down with symptoms of heart failure, you know, the difference in her EGFR, the left ventricular ejection fraction was 5, right? Pre and then post chemotherapy. So if she had symptoms of heart failure, that would have been defined at chemotherapy-induced cardiotoxicity. But because she didn't come down with symptoms of heart failure, so it's taken as she doesn't have chemotherapy-induced cardiotoxicity, meaning that the definition for chemotherapy-induced cardiotoxicity is when the left ventricular ejection fraction is 5 and above, when there's reduction in the left ventricular ejection fraction of 5 and above with presence of heart failure. That's the patient is having heart failure, symptoms of heart failure. Once the ejection fraction is greater than 5 or greater than 5 in its reduction, like for example, pre-chemotherapy, ejection fraction was 65. And then post-chemotherapy, it then became 60. And the patient has features suggestive of heart failure, maybe using the Framingham criteria. That's taken as cardiotoxicity. But in this case, she was asymptomatic. So in asymptomatic case, it has to be 10 and above. So that's why she doesn't fit in for the criteria for chemotherapy-induced cardiotoxicity. Then aside beta blockers and ACIs or ARBs, we also have what we call the dexranone. That could also be used, but it's not commonly available here. Then also those antioxidants like the vitamin A, vitamin E, vitamin C. What they do is that they mop up the free radicals to prevent further apoptotic formation on the myocardium. So that's just an addition I just had to put that because the patient is asymptomatic, that's why the patient doesn't meet the criteria for chemotherapy-induced cardiotoxicity. But if the patient was symptomatic, having heart failure, that patient with 5 or ejection fraction, that's the difference between the pre and the post, the patient would have been deemed as having chemotherapy-induced cardiotoxicity. Thank you. I don't know if I was well understood.
Yes, thank you very much for the thank you. Okay, so question number 84. Which of the following statements concerning cardiac catheterization evaluation of valve orifice areas is true? So the background is that for a better estimation or determination of valve areas when planning for valve replacement surgeries, cardiac catheterization can actually be employed to do so. And then, so that's like an invasive form, though we know the other non-invasive forms where we use the planimetry and then the continuity equation and the likes. So I'll take it one by one using the options. So A, valve area is calculated by the Gaulian formula. Valve area as calculated by the Gaulian formula is inversely proportional to the flow across the valve. So the Gaulian equation, we have Gaulian equation for both the aortic and mitral valve area estimation. But the basic is that there's all called the flow equation. So flow is equal to area times the velocity. So here now, area will now be equal to the flow divided by the velocity. So using this equation, we can see that area is actually directly proportional to the flow and not inversely as proposed by this first statement. So the Gaulian formula, we have the original Gaulian formula, which is the flow equals to area times the velocity, where the area will now be equal to flow divided by the velocity. So area is actually directly proportional to flow and inversely proportional to the velocity. So that makes this option A false. Then accompanying valvular regurgitation will result in falsely high calculated valve area because actual flow across the valve is less than the flow calculated from the systemic cardiac output. So the modified Gaulian equation now they've been able to modify the Gaussian equation by using the calculation of the cardiac output, the heart rate, the systolic ejection period, and then the square root of the mean gradient. So that's the things required in this equation. When I'm done with the presentation, I'll send some links where we can read and see this equation. But for aortic valve area estimation, we have the cardiac output divided by the heart rate. That's all divided by the heart rate multiplied by the systolic ejection period. And there's a constant, 44.5, and then the square root of the mean gradient. And what we should know that the cardiac output is usually determined by the fixed method or the thermodilution method. The fixed method is said to be more accurate than the thermodilution method, but then the fixed method, by the fixed method, cardiac output determination relies on flow across the valve. So when you have situations in which there may be reduction of flow, for example, where there's LV dysfunction, which will reduce the flow, there's not enough pump activity of the heart, the flow across that valve is going to be reduced. So it might give you a falsely low valve area estimation. Then in situation whereby there is regurgitation, so the actual flow across that valve is also reduced when there's significant regurgitation. This also causes a reduction in the calculation of the calculated valve area. So option B is also false because accompanying valvular regurgitation will result in a falsely low, not a falsely high calculated valve area. But the reason they were put in will be true for a falsely low calculated valve area because the actual flow across the valve is less than the flow calculated from the systemic cardiac output because there's a there's a backward flow. So flow across the valve is actually reduced. Then for the C option, calculation of the mitral valve area typically relies on substitution of a confirmed pulmonary capillary wedge pressure for left atrial pressure. So during cardiac catheterization, when the pulmonary capillary wedge pressure is when it is obtained, is assumed to be the same with or a reflection of the left atrial pressure. Because like we all know, if there are no obstructions across between both the left atrium and the pulmonary arteries, we expect the pressure both in the pulmonary artery and the pulmonary capillaries and the left atrium to be the same. Okay, so that makes that the correct option. The option D, valve area calculation, is more strongly influenced by errors in the pressure gradient measurement than by errors in cardiac output measurement. So if we go back to the initial formula that I said, that we have the valve area where we say the cardiac output will be divided by the systolic ejection period, the heart rate, the constant, which is 44.3, and then square root of the mean pressure gradient. So if there are errors in the measurement of the mean pressure gradient, it's said to be very reduced because we're actually just taking the square root of this mean pressure gradient, okay, in the calculation of this valve area. And this is different from where the flow which influences the cardiac output is used. So for valve area calculation is actually strongly influenced by the cardiac output measurement. So that's why the flow across the valve that will be used in calculation of the cardiac output measurements must be done as accurately as possible, as it's going to have a lot of influence on the valve area that is calculated rather than that pressure gradient. So for question 84, C is the correct answer. That calculation of mitral valve area typically relies on substitution of a confirmed pulmonary capillary wedge pressure for the left atrial pressure. I don't know if we have any questions or comments or clarifications.
Okay,
Hello?
I think you can proceed to the last question. That's 85, right?
Yes. Thank you very
Okay,
much.
thank you.
Okay, so question number 85. A 56-year-old man who underwent coronary artery bypass graft 6 years ago has experienced exertional chest discomfort in recent months. He is not able to perform an exercise test because of chronic hip pain. So he undergoes an adenosine positron emission tomography vasodilator stress test. And the images are shown in the figure below. What is the correct interpretation of this study? Please, could you kindly scroll to the image? Thank you. Figure 1.21. Okay, so with the background of what we discussed earlier, so this positron emission tomography scan is this is one that is done at rest and during stress. So the method of stress that have been used here is the pharmacologic using adenosine, because they told us that the patient has chronic hip pain, so the patient will not be able to go on a treadmill. So like I said earlier, there are two different types. The perfusion, that's for the perfusion imaging using the flow tracers, or the metabolic imaging. So the metabolic imaging was what we discussed in the earlier question. So this one is mainly perfusion imaging. And the isotopes that can be used are rubidium-82 and nitrogen-13 ammonia. So here we have in the first two imaging, we have the short axis showing the apex and the base. And then the mid part, we have the horizontal long axis, and then the lower part, we have the vertical long axis. So what is prominent here is, so the principle, like I explained earlier, is that during rest, at rest, we may find normal perfusion. So how to interpret this flow tracing is that at rest, you can find normal flow, but during stress, so during a stress test, you will now be able to find defects that would show that there is stress-induced obstruction or narrowing of the coronary arteries. So for this image, if you look at the vertical long axis area, we'll see that even the horizontal long axis, that's the mid portion images, the horizontal long axis showing the inferior and anterior, we can see that at rest, the only place where you have reduced flow at rest is about between 12 and 1 o'clock. But during stress, you can see it extending from about 9 o'clock till about 1 o'clock. So during, especially if you look at the middle column now, that's when you count 1, 2, 3, you would see that for the stress and the rest, there's marked reduction in the flow tracing during stress, but that is reversible at rest. That is not present at rest. So the flow is normal at rest, but during stress, when there's occlusion of the coronary arteries, the flow tracer, there's reduction of flow. So that's to tell you that there's some obstruction going on there. So we'll go back to the options, please. Please, can we scroll up to the options? Thank you. So A options says that, so they said they're asking us what is the correct interpretation of the study. The A option says no perfusion defects. That's false. We've been able to identify stress-induced perfusion defects in that horizontal long axis region that we said worsened from about 9 o'clock to about 12 o'clock. Then B, a partially reversible defect in the inferior wall. If we go back to the picture, see that, thank you very much. So if we go back to the pictures, we'll see that the defects during the stress, they actually worsened. So, and reversibility, we can't determine reversibility here in only the flow tracing PET. Reversibility would have to be compared with the myocardial, the metabolic one, that's the FDG tracer one. That's what we use to determine if this flow defect that we are seeing is reversible or not. Okay. Thank you. Please, can we go back to the options now? Thank you very much. So C, a severe predominantly reversible defect of the anterior wall. D, a fixed defect of the anterior wall without reversibility. Then E, fixed defects in the apex and lateral walls. So I want to knock off D and E first, because we said that fixed defects means that they are present both at rest and during stress, which is not what we found here. The defects that we found here were majorly stress induced. Those are the defects we found here. So that takes out D and E. So the answer they actually picked is C. Said it's severe and predominantly reversible. I can actually see the severity because from that last image that we checked, we can see that there's an extensive area of flow defect in the filling, but at this point, I'm still unable to say which part was inferior or anterior. That's determining the orientation of the images that were given. But C was the answer that they picked, that there was a severe, predominantly reversible defect in the anterior wall. So I don't know if we have anyone who can give more clarification on that. Hello.
Hello, Dr. Basri. Hold on.
Thank you. I don't know if Dr. Rivanadi is still awake. If she can throw more light. Or Dr. Conte. Okay.
Yeah, hello. I think I also need to take a closer look at defining the territories. Being able to identify the perfusion defects is now a bit clear, but the territories are a bit different from what we see on echocardiography. So I'll have to take a closer look at that and understand how to identify the distribution of the vessels.
Okay, thank you very much. I would also seek more. I will also do some more work on it to see if I can get to understand it. Thank you so much for the opportunity. Okay, so I think that's the last question I have. So I think we might call it a day for tonight. Hello, Dr. Conte, over to you, sir.
Yes, thank you very much, everyone, for staying past 11 o'clock your time. So we'll continue tomorrow. Yeah, so tomorrow is the same time from 8 to 11. So have a restful night. Thank you.
Thank you very much. Well done.